a 41-year-old lady with a significant history of her husband having had open pulmonary tuberculosis 5 years back, treated with ATT for 6 months. No history of substance use or abuse, presented with cough and reddish discoloration of sputum, cough for a year and reddish discoloration for 4 months. The cough was persistent, episodically worsening, productive cough associated with expectoration of sputum with a mucoid consistency. No, there was no history suggestive of postural variation, diurnal variation, chest pain or discomfort. No shortness of breath was present. The reddish discoloration was initially noticed as a single episode of reddish streaking in the expectorated sputum 4 months back. However, she has had multiple episodes since then of passage of sputum with reddish discoloration or reddish streaking over the past 1 week. So this has been associated with a change in the consistency of sputum, yellowish discoloration and more runny, and there is a low-grade undocumented fever. At present, there is no history suggestive of, again, postural variation, diurnal variation, chest pain or discomfort, or shortness of breath. The trachea is central on examination. Bilateral vesicular breath sounds are heard. Bibasal mid to late end inspiratory coarse crepitations are audible. They change with cough, but okay. So let's localize our pathology as we've done for our first case. Similarly, in our second case. This is the schematic that I had used in the first case for our respiratory tract. Okay, the schematic remains the same. This is our proximal airway. This is our distal airway. The primary bronchus undergoes 23 generations. The last 7 generations are called the distal airway. They open up into the alveoli. There is a pulmonary capillary bed just juxtaposed right next to the alveoli. There is a little bit of interstitium in between the alveoli, and this is the entire setup is housed within 2 layers of pleura, the visceral pleura and the parietal pleura. It is the parietal pleura that gets somatic nerve supply and therefore is pain sensitive. Outside of which we've got our chest wall, which in the lower end of the thorax consists of your diaphragm, and the lateral aspects are obviously consisting of the ribs, the intercostal muscles, the subcutaneous fat, and then the chest wall or the skin. So just like shortness of breath, and we've discussed this in our discussion on shortness of breath as well, but now I'm going to highlight how a patient presenting primarily with a cough with or without hemoptysis is likely to present. Okay, so this is again the same anatomical framework that we used. So proximal airway disorders like asthma or COPD are unlikely to present with hemoptysis, so that essentially can be ruled out. Okay, now distal airway disorders like chronic bronchitis and bronchiectasis are likely to present with hemoptysis, and we discussed epidemiologically speaking this is the most common location from which you get hemoptysis. But as you can see, they also have prominent cough. So they typically have a concomitant mucoid or mucopurulent cough that accompanies the hemoptysis, and it is usually the mucoid or mucopurulent cough that is the productive cough that is the predominant complaint. Okay, so I'm going to label this, that is your bronchitis, as entity A. You can remember it as acute bronchitis. So it is A. Acute bronchitis is by far the most common cause of hemoptysis. The second entity I'm going to label B. Okay, obviously this is acute bronchitis and this is bronchiectasis. Now, see, alveolar disorders that we discussed primarily result in shortness of breath. However, they may also have hemoptysis. So let's shade over the dyspnea part of it and see where the hemoptysis leads us. So we discussed that malignant disorders can cause hemoptysis. Okay, so malignancy for cancer, we'll call it C. And similarly, bleeding into the alveoli, breach in the alveolar capillary membrane resulting in blood coming into the alveolar lumen would produce diffuse alveolar hemorrhage, and that we'll call D. The thing is, what would be the character of the blood or the secretions that the patient would have? See, these are alveoli. Unless there is an infection within the alveoli, as in it is a pneumonia, Otherwise, all other alveolar pathology would result in the patient coughing up blood, either purely blood or a little bit of serous fluid, clear watery fluid is what often patients describe it as, which then, because it is just serous fluid, there are no enzymes or neutrophil enzymes or inflammatory enzymes there. It doesn't lyse clots that are forming within the blood that has entered the lumen of the alveoli. So because of that, what ends up happening is eventually you may have clotting of the blood. Patient may give you a history of initially passing watery secretions or sputum with a little bit of blood streaking, and then eventually passing proper clots. Although obviously this is not a definite thing, it might in that case indicate that the patient is having a primary alveolar origin of the hemoptysis. Now note, this is noticeably different from what you get with distal airway disorders, because there you get mucoid or mucopurulent secretions accompanying the hemoptysis, because alveoli don't contain any cells that secrete pus, okay, or rather secrete mucus. Okay. Now however, if you have an infection there, that changes. So in infectious pathologies, what we would call a necrotizing pneumonia, or if there is a prominent inflammatory response and you develop a cavity there, as in a lung abscess, this same pathology, even though it is alveolar, may produce mucopurulent or mucoid. So what is important is clinically, does the patient say there is passage of clear fluid, or is it passage of mucoid or mucopurulent fluid along with the blood, and is the blood clotting? Okay, so if it is pure mucoid or mucopurulent secretions that are being sent, we can't really be sure whether it is the distal airway or the alveoli within infective pathology. All we know it is that there is some kind of inflammation with a prominent innate immune activation with neutrophilic infiltration that is causing the problem. Okay. However, if it is clear, okay, and importantly, the patient doesn't have systemic features suggestive of an infection, okay, doesn't have prominent fever, doesn't have, those features are not there, or they are not very minimal in the history, then you must strongly consider the possibility of a diffuse alveolar hemorrhage. Okay, so as I've just discussed, would this hemoptysis result in a mucoid or mucopurulent secretion? It might, but it also might not. So if you have prominent, the secretion is predominantly watery with clots, then you are strongly suspecting a primary alveolar origin of the bleed. Okay, this is not something that has been tested as for its sensitivity and specificity, but anecdotally speaking, this does happen. Okay. Next, we have hemoptysis arising from pulmonary vascular disorder. So obviously, interstitial disorders that predominantly involve the interstitial region but don't involve the alveoli don't have, even if there is bleeding, they don't have a avenue for the blood to reach into the alveolar lumen and therefore come out. So the patient would not develop hemoptysis. Similarly, we've discussed that pulmonary interstitial disorders primarily present with dry cough. On the other hand, pulmonary vascular disorders are definitionally vascular disorders. So they would cause a loss of vascular integrity, and leaking of that blood may occur into the alveolar capillary, the alveolar lumen. So let's just label this pulmonary embolism here as E for embolism. Okay, and we may have structural abnormalities that we'll call because structural abnormalities, and usually these are not causes of hemoptysis that are commonly seen or to be suspected in an adult patient very often. Although secondary structural abnormalities, say due to a tubercular cavity or something like that, or an abscess, are obviously something that you must consider. Okay, so now you see why I've been labeling everything like that. We've got F for foreign bodies, G for GPA, but even without GPA is granulomatosis with polyangiitis, but even without diffuse alveolar hemorrhage. And why is this the case? Because GPA also causes nodules which can undergo cavitation. So GPA nodules and also other diseases that cause nodules can cavitate, and that can produce hemoptysis. Then hemostatic abnormalities. This technically also comes under the broad heading of DAH, okay, or alveolar hemorrhage. But the thing is that it is actually divided into capillaritis, that is inflammation within the alveolar capillary bed, which is or endothelial inflammation, which is causing a loss of integrity of the alveolar capillary lumen with blood entering into the alveoli themselves. Okay, or it could be a hemostatic abnormality. So there could be a problem with hemostasis, with a platelet type bleeding disorder or a coagulopathy. Importantly, however, a primary hemostatic abnormality very rarely would result in alveolar hemorrhage. Okay, so there is usually something else predisposing the patient to bleeding from the lung, because you would expect to occur in other locations earlier. Okay, then we have finally infections. So infections is like, okay, so causes of hemoptysis can be very neatly remembered using this mnemonic of mine. That is A for acute bronchitis, but obviously it is acute or chronic. Then B stands for bronchiectasis, or you can add bronchitis here for chronic bronchitis. C stands for cancer, that is malignancy. D stands for diffuse alveolar hemorrhage. E stands for embolism. Now, importantly, till E, all of the entities that cause hemoptysis have a clear anatomical localization, and this will become very relevant when it has become relevant already, because that determines what kind of secretions occur with the hemoptysis. But it will also become relevant later when we are doing analysis of imaging of the CT findings in these disorders. So obviously bronchitis will occur in proximal airways or distal airways. Okay, so chronic bronchitis obviously occurs in distal airways. Bronchiectasis would occur in distal airways. Similarly, your cancer can occur anywhere actually, from proximal, distal, or alveolar, but usually is alveolar. Then diffuse alveolar hemorrhage, that obviously is by definition alveolar. Then embolisms obviously by definition are pulmonary vascular. Then AV malformations, distal to this, all of these disorders can occur absolutely anywhere. You can have AV malformations which can be anywhere. Foreign bodies, which are typically proximal airways, but they can, depending on the size of the foreign body, go a little bit distally. Then GPA nodules are variable, they occur anywhere within the lung. Hemostatic abnormalities typically cause alveolar hemorrhage, but it can also result in bleeding from other locations. So, and infections again can occur when we are within the lung. So that is it. So it is neatly called using this mnemonic A, B, C, D, E, and F, G, H, I. Okay, so please don't forget the and, because and A stands for AV malformation. So now the thing is that why am I discussing this separately from shortness of breath? So there are patients who present with a prominent cough and or hemoptysis without shortness of breath, or very minimal or late onset of shortness of breath. So the thing is that cough could indicate an underlying infection, and some infections are major issues for the patient, but also for people who have been exposed to it. So as a physician, obviously we need to also think about other people getting exposed to the infection. We need to have a very systematic and consistent approach to patients with cough, and naturally hemoptysis can be life threatening, so that to hemoptysis itself. Whereas with shortness of breath, it is more of a intensive clinical history and examination, and then obviously workup that is indicated. So invariably both algorithms for cough and hemoptysis will lead to imaging. The algorithms basically are supposed to tell you whether to do imaging or not to do imaging. Okay, so we start with, that is chronic cough lasting for more than or equal to 8 weeks. Now why 8 weeks? Because at less than 3 weeks, that is called acute cough. Okay, so acute cough is most likely due to an upper respiratory tract infection, so that is need not be evaluated. Whereas 3 to 8 weeks, it is most commonly due to acute bronchitis, okay, or a post-viral syndrome. So in these two situations, we don't typically have a need to evaluate the patient. Okay, so we can wait and watch. However, in India or in other countries where tuberculosis is endemic, often the cutoff for evaluation of these disorders is reduced. So We typically use a cutoff of 1 to 2 weeks, typically 1 week, okay, in India. But again, as an internal medicine doctor evaluating IPD patients, inpatients, or evaluating very unwell OPD patients, or as a subspecialist who does not specialize in an organ, you will not usually be exposed to such patients, or will see them only in an outpatient setting. So that is a nuance that needs to be kept in mind as you evaluate these cases. Okay, so what do? We either wait for the cough to last for 8 weeks, or we basically see are there any red flag signs. So what are these red flag signs? These are signs that indicate that there is either an underlying malignancy, or they indicate that there is an underlying severe infection, or they indicate significant physiological compromise. Okay, so malignancy risk would increase if the patient is elderly, if the patient has developed unintentional weight loss, there is any significant history of smoking, malignancy risk will increase. Similarly, you would have a chest pain, shortness of breath, or hemoptysis. Something the cough immediately mean that there is the disease is prominent and needs to be evaluated. Needs to be evaluated in detail, and that requires imaging. Okay. Similarly, an immunocompromised person invariably is likely to develop a severe infection, okay, invasive aspergillosis, so, or pneumocystis. So in that situation, we need to be a little bit more careful. Obviously, if the patient has an increased respiratory rate, is in type 1 respiratory failure, that is hypoxemia is there, or is in type 2 respiratory failure, then you need to evaluate. Also, if you get a focal defect while examining the respiratory system, okay, or the cardiovascular system, as we've discussed previously in the approach to chronic shortness of breath, then naturally we need to evaluate the patient. Okay, so if none of these things is there, that the cough has lasted for less than 8 weeks and there are no red flag signs, then we don't need to work up any further. So that situation, everything is fine, nothing needs to be done. On the other hand, if you have even one of these problems, then you need to do a chest x-ray. Now, whether you go for a chest x-ray or a CT scan is usually dependent on your pretest probability. So if your pretest probability of a significant disorder, okay, say alveolar hemorrhage or infection, is quite high, you could directly go for an HRCT. However, if it is low, you are essentially trying to rule out significant pathology. So you do a chest x-ray, and if it is normal, you essentially rule it out. Okay. So that is why the chest x-ray is the first thing. But in some situations, you may consider starting with a CT scan. But again, unnecessary, inappropriate usage of CT is not a good idea, because the dose of radiation that the patient, of ionizing radiation that the patient gets with CT is much higher than that with chest X-ray. Almost 1,000 chest X-rays equivalent to one CT. Okay, even with present day modern multi-detector CTs and third generation CTs and all that. So that is something that we need to be careful about. And obviously, see, in these particular situations, the protocol of the CT would dictate that you take very thin slices. Okay, so again, the dosage to the patient will be quite high. That is something that a physician should keep in mind while prescribing or deciding on what investigation is to be done. Essentially, a chest X-ray is to rule out any significant pathologies, whereas an HRCT or a high resolution CT scan of the chest has significant specificity gains over a chest X-ray, so that can be used to rule in a disorder. Okay, so you need to decide whether the pretest probability is high or low. If the pretest probability is high, you want to rule in the disease. So because you want to rule in the disease, you go for a CT scan. If not, you go for a chest X-ray because you want to rule out the disease. In step 2, what we do is we evaluate, is the chest X-ray normal because the patient has a proximal airway disease, or is the disease maybe outside of the respiratory tract, therefore it is not coming in the chest X-ray? Is that a possibility? Okay, so there are some very specific pathologies that need to be considered in that situation. So they may be pathologies that are so proximal in the airway that they are not clearly visible on the chest X-ray. So again, what could that be? Again, like I said, most common cause of acute cough that is lasting for less than 3 weeks is an acute viral upper respiratory tract infection. That will not come up in this thing. So that would have a normal chest X-ray and require no further workup. The most common cause of a subacute cough is actually a bronchitis, acute bronchitis, or a post-viral syndrome. So both of those would come under proximal airway disorders. Okay, so A, and then B would be bronchial asthma. Okay, so there is an variant of asthma which we'll discuss in the discussion on asthma, called cough variant asthma. So cough variant asthma can present obviously with cough. Then we have C, that is for chronic bronchitis. So all of these disorders that I've discussed till now are proximal airway disorders. They affect the trachea, the primary bronchi. So that's why they don't come with it. And D stands for delayed post-viral syndrome. Again, not a very prominent or important entity to evaluate. Lastly, we have a chronic eosinophilic bronchitis. Now, chronic eosinophilic bronchitis has by definition sputum with eosinophils more than 3%. So for this, you'll have to evaluate the sputum. So this is why to rule out these disorders, you typically have to do a sputum analysis. Okay, so X-ray is normal, and particularly in India, we typically send a sputum for gram stain. We send it for cultures, and most importantly, we send it for AFB and CBNet. That is to rule out tuberculosis. So that is a very important thing, and that has to be done almost in every patient. On the other hand, we have pathology that may be outside of the respiratory tract. Okay, so it could be an upper respiratory tract problem, or it could be cough due to irritation of the lower esophagus. So that can happen with a gastroesophageal reflux, and it can happen with any lower esophageal disorder. Now, it can also happen with a laryngeal problem, or it can be a general problem due to angioedema that happens with ACE inhibitors. So these are three things that you must consider if there is no significant cough production and the patient is primarily having a dry cough, but it is persistent. Now, once all of these entities have been clinically ruled out, what we are left with is essentially a decision as to do we evaluate further or do we not evaluate further. So we can actually go in for a CT, but it has to be a non-contrast high resolution CT with a contrast enhanced CT to rule out or to beat 4 specific entities which may come in patients who have a normal chest X-ray. That is beat. You must beat these entities. Okay, so that is bronchiectasis, early ILD, atypical mycobacterial infections. Okay, and finally we have tumors, so early tumors. So again, the pretest probability has to be assessed. Only if the pretest probability is high, you go for a CT. Okay, if it is low, ideally I wouldn't go for a CT. So everything depends on the pretest probability. Now, if you have done a CT and that comes out to be normal and everything else is normal, then you're left with actually just one single disease known as cough hypersensitivity syndrome, which is actually due to increased expression of the transient receptor potential V1 receptor, okay, which is basically a receptor that is located on unmyelinated C-type fibers or nerve fibers that are present within the airway and the lower esophageal sphincter, and that results in unnecessary cough that keeps happening, and usually is precipitated by talking, laughing, any kind of exercise, anything that causes drying of the airways. And usually these patients complain of a tickling sensation while coughing. Very importantly, this is a diagnosis of exclusion. Okay, and not in all cases would you be diagnosing things by exclusion. So moving over to a systematic approach to hemoptysis. So in case of hemoptysis, what you end up getting is, first thing to decide is it truly hemoptysis or not. So first step is hemoptysis or hematemesis, that is the bleeding from the upper respiratory tract or is it from the upper GI tract. So the upper GI tract, if it is from the stomach, which is the most common location, usually has bleeding into the stomach, which is acidic, and because it is acidic, it converts your blood into it changes the hemoglobin and ends up producing a brownish pigment. Okay, so because of that, the blood that will come out of the patient will have changed color to brown or black. The second thing is the consistency will be grounded coffee like. Okay, it really looks like coffee grounds. And finally, if you check the pH, there will be acidic pH. Now there may be associated GI symptoms. So in the other case, we'll have hemoptysis, which will be primarily associated with respiratory symptoms. Now, once you are reasonably sure that it is hemoptysis, not hematemesis, okay, we go in for a assessment of, so once we, the differentiation is quite straightforward, we go in for the second step. Okay, so what is the second step? We look for feature suggestive acute bronchitis. Okay, because we don't really want to do a chest X-ray or a CT, so we go for associated acute bronchitis. So acute bronchitis can be assessed based on three things. How severe is the hemoptysis? Is it mild? So if it is mild, this is just a single episode and there are no other clinical findings based on history or on physical examination, then it is acute bronchitis and you don't really need to go into any details further. Okay. However, if you have the slightest bit of doubt, please go in for a imaging. Okay. So if there is even one, okay, you will go in for an imaging. Now, importantly, smoking increases the pretest probability of malignancy significantly. Therefore, if the patient is a smoker, even if there is history that suggests acute bronchitis, it is always prudent to directly go for imaging. So even if the patient is a smoker and is there is anything that suggests to you that it is not acute bronchitis, please go in for imaging. Okay, so in imaging, what do we go in for? We go in for a chest X-ray or we go in for a CT scan. Okay, but a CT scan would always be preferred over a chest X-ray, again because hemoptysis typically has insidious etiologies as compared to cough. Okay, so now we go in for our last thing, that is we need to decide, is your hemoptysis, is it likely to be originating from the bronchial arteries or the pulmonary arteries? Now, there is an entity known as Rasmussen aneurysm. Now, that is a dilatation of a pulmonary artery within a cavity, classically caused by tuberculosis, but could be due to other reasons also. And that is a pulmonary arterial hemorrhage. Okay, whereas you can also get original bleeding from the bronchial arteries, and that is actually more common epidemiologically speaking than pulmonary artery hemorrhage. So what origin is it likely to be from is also a consideration. So if you're going to do contrast enhanced imaging, you're going to have to consider this, whether it is from a bronchial artery origin or is it from a pulmonary artery origin. Now, pulmonary artery obviously is part of the pulmonary circulation, whereas the bronchial arteries are direct branches from the aorta, and therefore you would end up having to do a contrast and enhanced aortogram if your CT scan is doubtful or there is nothing clearly that can be attributed and does not further workup for that entity that is visible on a CT scan is not warranted. We find is that in summary, we have a 41-year-old lady with a history of open pulmonary tuberculosis in her husband 5 years back, who is now presented with persistent, episodically worsening, productive chronic cough with a mucoid consistency and multiple episodes of hemoptysis, which have increased in frequency over the last 1 week and are associated with a change in the sputum consistency as well as low-grade undocumented fever. And on examination, the trachea is central. There are no bronchial breath sounds, and there are bibasal mid to late end inspiratory coarse crepitations, which change with cough and not with patient position. Okay, so I've highlighted the important bits of the history, and let's use our analysis of our diagnostic framework for cough and hemoptysis to come up with a likely tissue diagnosis or tissue localization from where this is from, for that would explain the patient's symptoms, and also come up with a likely pathological entity that may be responsible. Okay, so right off the bat, we have an episodically worsening productive cough. So we know that whatever it is, the pathology is in communication with the airway. Okay, so this is somewhere along the respiratory tract from the alveoli, distal bronchioles, proximal airways, and then right up till the trachea. Okay, now in addition to that, we know that there is the cough is associated with sputum of mucoid consistency. So there is something producing mucus or mucin or glycosaminoglycans. So those cells, as we've discussed in our discussion on an approach to chronic shortness of breath, are primarily located within the distal bronchioles, because they contain mucus glands as well as Clara cells, and sometimes in hypertrophied mucus glands in proximal airways. Okay, so this is distal more than proximal airway. So something odd is happening. Along with that, she's developed episodes of hemoptysis. Okay, there is bleeding that has been noticed along with a change in the sputum consistency. So how do we know this is hemoptysis and not hematemesis? Because it is a reddish, so it is not darkish in color, and the consistency has not been described as ground coffee grounds. And the other reason is there is a concomitant respiratory symptom, which importantly here is changing in its character. Okay, now the next thing that we can see is that once we know it is hemoptysis, it is to be reasoned that the site of origin of bleed, that means the bleed is also in communication with the respiratory tract. That is how it is, the blood is getting expectorated out. So it stands to reason that likely the pathology is in the same location. Okay, so it is distal more than proximal airway. And if there is a change in the sputum consistency, that means that initially the sputum was primarily consisting of hydrophilic, glycosaminoglycans, but now it is becoming runny, it's becoming thin. So maybe what is happening is there is an inflammatory pathology there that is causing neutrophils and other innate immune cells to infiltrate into this area and then start producing extracellular enzymes. And that is digesting the proteinaceous material that forms the mucin and holds the water together to give it its consistency. Along with that, we have a low-grade undocumented fever. Okay, so that means we know there is some kind of inflammation happening. It may be against an infective agent, it may be a primary problem with the immune system, but there is some kind of inflammation happening. Okay, then finally we use our knowledge of the pulmonary physical exam to understand that this patient has mid to late inspiratory coarse crepitations. Okay, so as we discussed, fine crepitations and coarse crepitations are non-musical added sounds that we hear in the lung. So coarse crepitations result from the movement of boluses of air, okay, during the respiratory cycle between the proximal and distal parts of the distal airway, and the boluses get stuck at various locations within the respiratory tract, and where they get stuck depends on the size of the bolus, okay, the consistency of the fluid through which they're going, and often that results in air spaces of differing with each respiratory cycle of different length. Okay, and that closed pipe system then produces a resonant wave, and therefore the waves that are produced are of varying size and varying there are of varying frequency, and therefore the combined wave, the entire envelope that you get, doesn't show a normal musical wave pattern, and doesn't show the characteristic gradual sinusoidal changes that you see in musical waves. So this indicates that there is some kind of secretion within the distal airways, again corroborating with our expected findings on history, based on history. And within the distal airway there are some bubbles of air that have gotten stuck, and they seem to be producing this mid to late end inspiratory coarse crepitations, and we've confirmed that by checking their change with coughing. So with cough, the secretions change in their relative distribution within the lung, and therefore the crepitations also change. Whereas with patient position, there is no significant change, which if it was these were fine end inspiratory crepitations due to fibrosis, because the vector of gravity would change, there would be a change. So finally we'd say that it is the distal airway that is affected. Okay, and we know distal airway can be affected by two things: chronic bronchitis and bronchiectasis, and these entities require their own diagnostic evaluation and an understanding of the background pathology, the pathogenesis of these disorders. So in subsequent videos in the series, we'll be delving deep into this, and also using the concepts that we learned to understand the imaging, relevant imaging that needs to be analyzed in cases of this sort. So I hope to see you in the subsequent videos, and have a nice day. I'll see you next time.